Hi everybody. I'm really honored to be here, and I need to thank, of course, the president of the Congress and the EGA, and everyone of the organization because everything is fantastic. So I'll talk about arthroscopic reduction and internal fixation of the trauma lesion of the shoulder, and I also need to thank my director and mentor, Dr. Gervasi. Okay. So let's say we can start with simple issues that might be the humeral tuberosity fracture and the clavicle fracture dislocation. This is going to be the subject of the next uh, presenter. So we'll address the first, the humeral tuberosity fracture, and then something a little bit more complicated like the glenoid fracture. Starting from the first, we might say which is the indication. So nowadays, from 5 millimeters of displacement, we move to 3 or more millimeters of displacement. But we must take into account also the timing, because as long as the time passes from the fracture, as long as the displacement of the tuberosity is more severe, you'll need much more force to reduce the fracture and also to fixate it. So in some reviews, we also can find how the sutures that we use during arthroscopy are have less complication and reoperation than the screws. Some other papers, recent papers, tell us that from an clinical point of view, the outcome are more or less the one that you can find with ORIF. But in this paper, for example, they performed 3 arthroscopy and 1 ORIF. Last but not least, the treatment with plates. So again, ORIF, but the use of plates is a little bit discussed in the literature, but there is yet favoring the arthroscopy treatment idea. The techniques, every year came up constantly new techniques. Maybe it's due to all the new tools that we have, but it's now really messy in the literature because very simple things can change and everybody describe a new technique. But besides that, what is really important, and we can see in this review, it's that during the arthroscopic procedure, you need a strong fixation of the tuberosity, like with suture bridge and double repair, and of the fixation on the humerus as well. So you need some strength to pull them back in place and to hang them to the humerus again. There is some papers about lesser tuberosity as well with good results at the same time. I'll focus on the greater tuberosity fracture. This is a case of a fracture. We have performed the rip and stop technique, and you can see the tuberosity goes back in place and it's going to heal. There are some other cases where you don't have the same amount of bony fracture, so not only one fragment, but multi-fragmentary portion of the bone, and this looks like a rotator cuff repair in a double row fashion. This last case is maybe the most important because it's about the timing. We saw this patient 2 months after the fracture. He wasn't treated, so we, with a great effort, performed what we thought was a good job, a strong repair, but the next day, this is what we found out. So this is what makes us think one more time that time is a factor, and also the strength of the fixation that you give on the humerus. You can also combine the arthroscopic and the open procedure, but what we sometimes do is to use a screw and a washer distal to the fracture, so where the bone is good, and not use the screw to reduce the fragment, but to hang to it the suture that we placed in the arthroscopy. Let's move to glenoid fracture, which is not what we heard today from really prepared speakers. So not small fragment and not the shoulder instability, but bigger fragment that maybe have the same issue, but you need to address the fracture and not the instability. So some of these cases of Dr. Gervasi are in the book of the scapular fractures, where you can also find the classification, which is the first step to decide whether or not you want to treat the fracture. So the Heidelberg classification is well known, and now we have the AO classification, which is based on the CT scans. But whatever the classification you use, you have to decide if you want to treat the fracture or not. And the literature, in particular here, I use the review of the effort, says that surgery has at least as good as non-surgical treatment effective performance on these people. So there is no clear advantage for surgery. What makes a really big difference sometimes is the experience of the surgeon that knows if it's worth to treat it or not, and if it could be a good choice. Effort at the same time gives us the indication when we should treat this fracture. So displacement of the lateral column by at least 25 millimeters, angular deformity of at least 45 degrees, intraarticular steps of 3 to 5 millimeters, and double disruption of the superior suspensory complex. But there are also some other factors that we need to keep in mind. So the glenoid joint surface tolerate really well a little bit of incongruity. The paper that you can find in the literature when we came up to RF talk about mostly of Heidelberg type 1 factor, so the anterior inferior fracture. And in the recent year, there are several more arthroscopic procedures, maybe because of all the tools that we now have. But at the same time, you should always remember that you can combine the arthroscopic and the open technique when you need to assess big fragments. And what makes a real difference, as said in all these papers listed here, is the experience of the surgeon that needs to address the shoulder, needs to know how to address the shoulder in the arthroscopic as well as in the open procedure. Some other facts are that as you well know, the glenoid has a great healing potential, that the RF, if you're not confident enough with RF, can give you good to excellent results as well, and that in the end, you need to keep the fragments closed, but the perfect reduction is not a major problem. Coming back to RF, there are considerable advantage to RF if you are addressing Heidelberg type 1A, which is the most common studied in the literature. For what goes from type 3 to type 5 fractures, you'll find very few cases in the literature, and every one of these cases is different from one another, so it's really difficult to compare them. One last thing that we might want to say when we talk about RF in glenoid fracture, there is this nice study, comparative studies, that tells us that the green area that you see there in the glenoid is the one that you can address and see quite easily with the deltopectoral approach. Then there is the yellow area, that's the one that you can view with the Judea approach. But there is still an area, which is the red one, that you cannot easily address or see if you're not using a scope. So this is a good way to think about it when you want to use a combined approach. The moral of this is that if you decide to do or not to do it, you need to be experienced enough, because there is no trying this kind of fracture. So you need to know that if you start a procedure, you need to give the patient a better result. Some cases. So we have a superior glenoid fracture. The patient is positioned in a B-chair position. There is the arthroscopic view from the posterior that allow us to assess the fracture, mobilize a little bit the fragment, and to reduce it with some K wires from the Neviasier portal. And this allows us to use a screw to reduce and fixate the fracture. The second case, this patient come to the clinic after a couple of months, and with this kind of fracture, we saw that it's pretty well healed. We tried to mobilize the fragment, which was a little bit more still mobile, so we fixated with a couple of screws, but you see how well this healed. This is a third case, and as we saw before, it is maybe the most critical. So in this case, we decided to perform an arthroscopy, and that's what we saw, just getting in. So these might highlight that you need to decide before which is your plan. So we thought about there was a wrong indication. An experienced surgeon, which is Dr. Rebasi, went through the procedure and was able to reduce the fracture. Yes, it's not perfect, but it's only a little bit of a gap. And you see how with the screws, the articular surface of the glenoid is almost, we can say, perfect, or at least acceptable. But what you cannot address with arthroscopy, and that is something you should always keep in mind, is that the extra articular part is not something that you can do with the arthroscope. Going to some cases of the anterior-inferior fracture of the glenoid, there are more parts of the routine. You see here the kissing anchor suture technique. So we mobilize the fragment, freeing it from soft tissues. And once we are sure that we can reduce it properly, we proceed with the kissing anchor suture technique that Dr. Gervasi developed. So one anchor, suture anchor, no metal, for each side of the fragment, and then we tighten one another so that they are like kissing, and the knot stays inside. And if you want, you can also add some other peripheral knots with the anchors, but this is the result. And you can see as well is in this case, anterior-inferior fracture with two fragments. It's very important to mobilize the fragment from the soft tissue to be able to make them reducible, and then we use the kissing anchor techniques and then some repair of the capsule and the labrum in the periphery. On the right image, you can see how distal we can go with portals, but what we do when we need these portals is that we just, once we've tried with the needle, if the position is correct, we just cut the skin and then we go with the blunt dissection and using the half pipe to get inside the joint. And this is the result of the previous case and the CT 6 months after the operation. This is another case where we use the double row medial and lateral bone fragment repair, the Millet technique. So one suture anchor is placed on the glenoid rim and the other one more medial. The suture passes on the capsular area behind the fragment, and then you suture it, getting a nice reduction. This is the last case. Sorry for the color of the images, but it was nice because it happened just like 2 months ago. We mobilized the fragment as well, as you saw before. We performed the kissing anchor techniques, but what happened is one of the anchors, we had a pull out of one of the anchors. So we converted in a Millet technique, placing another anchor, but that one as well would suffer from a pull out. So you'll never know. You need to be enough experienced to manage every situation. At this point, we used the suture that were passing behind the fragment to do some sort of side-to-side, so peripheral reduction of the fracture. The reduction was not perfect, but as we know, it will heal. So to sum up this part, these fractures are really complex. To do or not to do is a factor, but you surely not start the procedure if you think you're going to try to do something. What is really important is that the surgeon must know how to address this fracture, either open or arthroscopically. He needs to have experience in both, because maybe the experience is what makes the difference in this kind of fractures. Thank you.